As Marika said, in the United States, when you get a clinical doctorate, PhD, you get trained both clinically and in research. Hello. And so I would primarily describe myself as someone who's a cognitive behavioral therapist. I specialize in anxiety, autism. That's where a lot of my clinical training was. But I have also worked in a psychiatric hospital setting. And so I provided care in inpatient, residential, and day treatment, kind of step-down facilities. So I've seen a range of psychopathology. After becoming a faculty member, I primarily now provide supervision. A lot of our research is in schools and also in outpatient community mental health care. So I'm licensed in the United States, so it means that I can practice clinical psychology, but primarily now I provide supervision to therapists who are learning how to do therapy. So I do have clinical experience, and hopefully that helps inform my research. All right, so today we'll be talking about the Alliance in Youth Psychosocial Treatment. And we're going to talk a little bit about the research and some about the clinical applications. And for those of you who just come in, I do want questions as I go along. So please, we can make this interactive and so forth. This is what I'm hoping to get through today. I'm actually starting out by talking about evidence-based practice. Then, what is the Alliance? What do we mean when we talk about the Alliance? What do we know about the strength of the relation between the Alliance and the quality of the relationship between the client and the therapist, and how that client does at the end of treatment? What research questions are out there? In our group, we've tried to address some of the gaps and tried to fill in some, but there's still a lot that we don't know about the Alliance. And in particular, we still have a lot to learn, in my opinion, about how to build the Alliance. How do we train therapists and clinicians to build a strong alliance with kids and families? Where do we go next? And if you haven't asked them all, then we'll have some time for questions at the end. All right. I'm living in Virginia, in particular in Richmond, Virginia. So if any of you have been to Washington, D.C., I do say Washington, D.C. It's kind of a dialect. It's about an hour and a half drive south of Washington if you don't hit traffic. And it's a town, or it's a city of about 1 million people. It's very ethnically and racially diverse, and with different levels of socioeconomic background, but it's a wonderful city, one that my wife and family have called home for almost 15 years now. I work at Virginia Commonwealth University. It's an urban campus. It's one of only 2 universities in the United States that actually started as a hospital and a medical training facility and then became a university about 45 years ago. We have 32,000 students. About 1/3 of those are medical students and graduate students. And we have 2 campuses that are about 10 to, we don't unfortunately bike or walk much in the United States. It's about a 10-minute drive across from each other. Our hospital is one of the biggest in the East Coast. It's huge. It's a trauma center. It's a very rich learning environment. And I work on the academic campus, and it's a fun campus. This is the only walking space in the campus. Most of it's throughout the downtown area. Something that my wife and I love about the university is that in the bylaws or the mission statement, we are to be community engaged. And so if you look at the faculty in the psychology department where I work, most of us have partnerships with community agencies that help define and shape our research. And so most of our collaborations are with the schools and outpatient community mental health centers. And we bring research ideas to them, they bring research ideas to us, and it's a wonderful partnership going back over 20 years. So we're very fortunate to have these strong partnerships. We have a nice river that goes through the city. It has rapids if you like to do whitewater rafting. But it's a fun city. We have 32 breweries, we have a lot of art, we have a lot to do. Marika can tell you a little bit about that. So I graduated about 15 years ago with my PhD. I am very interested in using our knowledge for science to improve practice in community settings. I've always been very interested in how treatment works for kids. When you're trying to help a child or a family and to get better outcomes and to have be more happy, less anxious, or whatever it may be, I've always been very curious, well, how do we do that? What are we changing in the child or family? What can I do as a therapist to help? How does the relationship play a role in that? And my goal has always been to use that knowledge to help make treatments work better in community settings. I think we have a lot of accumulated knowledge about treatments and about the Alliance. But we always, as scientists, I don't think we've always done a good job of making those treatments usable in the settings where most kids are receiving care. And so that's where I feel very strongly that, you know, yes, we could probably use more treatments, but I think probably more research needs to be done to help take that and make it usable by clinicians and better for families. All right, the first interactive component. How many of you are familiar with the term evidence-based practice? Excellent. Why don't you turn to a partner and tell that partner, just someone next to you, how do you define evidence-based practice? What would you all, you know, how would you define that? Just have a conversation with someone near you and take a few minutes to think about it. How do you define evidence-based practice?
If you need anything, just give me.
Okay, yeah. It's always interesting to see what people. All right, what are some of the definitions? So when you're talking to each other, what are how do you all define evidence-based practice? When you hear this term, what does this mean to you all? What are you telling each other? What are some of the parts that anyone, I'll call on someone. Techniques, yes, okay. Yes, very important. So scientific techniques. Is that part of some other folks? Okay, techniques. Combined with?
Experience from patients to clients.
Good, okay.
And practical knowledge from
okay.
professional.
Very good. You sound like you've read a little bit about it.
This morning we had a conversation about it and about how it's often explained in the Netherlands. Only you have to use the scientific evidence, but it's in a triangle. You have three aspects.
Yeah, we think of it as a stool, three-legged stool. Yeah. To sit on, yeah. So we're talking about scientific evidence and techniques, combined with practical knowledge and experience. And I think you may be wondering why I'm starting with this definition, but I think it helps frame the talk today. And this isn't the only definition, I don't want to say that, but this is a definition that is the American Psychological Association offered about 10 years ago. And I think it's important to kind of talk about this. It's evidence-based practice is the integration of the best available research with clinical expertise in a context of patient characteristics, cultures, and preferences. So it's not just the application of what we know scientifically, it's the ability to translate that into use with a client and to adapt it to what he or she may want or need. I'm more than happy to share these slides if, yes?
We proposed to the APA to add not only patient characteristics, cultural preferences, but also patients' or clients' experiential knowledge expertise.
Yeah, because I think increasingly, I think we're knowing that a client who is knowledgeable and educated about what they want and what is offered is going to be more able to collaborate and participate meaningfully in therapy. So yes, I would actually say, and at the end I'll get back to that idea too. But I heard techniques. How many people think the relationship's part of evidence-based practice, the alliance? Good, you got a couple of people? Yeah, so I'll follow this up with what is practice? Sorry, I will actually go on to, yes, so to promote effective practice and enhance public health by applying empirically supported principles of assessment, case formulation, the relationship, and intervention. Sometimes, unfortunately, in our field, in the broader mental health field, the conversation of evidence-based practice has been narrowly focused on treatment techniques or interventions. And I think we lose focus sometimes that this includes, in our statements, the importance of the therapeutic relationship or the alliance. That it's not one or the other, that we sometimes may be led to believe by this people writing about we should be doing these treatments or we should be doing this or we should do that. It's a collective effort, and I hope that if you walk away with something today that my message is in part that techniques in the alliance and the relationship need to be used together as part of a package of evidence-based practice. It's not one or the other, in my opinion. And I think it's damaging in our field when we talk about evidence-based practices is emphasizing one more than the other. They can work together because you need techniques to deliver or develop the alliance. We just unfortunately, as a field, have not done a good job of investigating those techniques. So here's the three legs of the stool. When we're training future practitioners and folks who will be working with youth and family, this is the model that I very much value. You teach individuals how to understand and access the literature, to know what the literature says, but that can only take someone so far because that tells you what generally works. If a treatment is shown to benefit, so one of my areas of expertise clinically is CBT for youth anxiety. Do you know what percentage of kids get better in CBT? And it's the strongest empirically supported treatment for anxiety. What percentage of kids do you think gets better? 55. So a little over half, and this is our strongest empirically supported treatment for anxiety. So that means at 45, almost half the kids aren't getting better. And so even if you are using the treatments with the strongest empirical support, not everyone is going to react to them. So we need to encourage the development of clinical expertise, the ability of a clinician to understand how to talk with someone, understand what their personal preferences are, what their personal knowledge is, how their culture and religion may impact what they want out of treatment, and to use this expertise to take the available research evidence and translate it for the person that's sitting in front of them, and to use that and to adapt it as they need to in order to help that person. And so this is where evidence-based practice lives, in the intersection of these three. And so I think it's very kind of important to kind of put this definition out there and to kind of help folks use this definition when we talk about evidence-based practice. I know you can't read all of this, it's very tiny. A couple of years ago, some friends of mine, actually some from the Netherlands, Julia Lieber, who's at Utrecht, and Christer Fjemmerstad, who's from Norway, two people I've had the pleasure of working with for a number of years. We wrote a chapter, and this chapter was focused on what can clinicians do to develop the Alliance. And so as part of that, we were trying to put together a model of how therapy works. It's very complex, right? So the client comes in, the therapist delivers some interventions and their level of competence. There's the Alliance, and then there's the degree to which the client is involved and understands and receives what is delivered. You change something in the client as part of treatment, you hope, and they have outcomes. Now, the point of the talk here isn't to kind of dig deep into this. I'm more than happy to send you a copy of the chapter if you should be interested in it. But I want to emphasize that out of all the psychotherapy research that we've done to date, the vast majority in the youth field has been in psychosocial treatments. What works for kids and families in terms of treatments and programs. And relatively little research has been done on the Alliance. It's a very important concept. Obviously, I'm very interested in it. I think it's very important for helping youth and families. But whereas there's about 50 studies on the Alliance in youth psychotherapy, there's over 350 in the adult field. And in adult psychotherapy, the amount of research on the Alliance is on almost equal footing with the research on treatments. Now, unfortunately, in the adult field too, these two groups do not see eye to eye, and they kind of are always arguing about what's more important, and I don't think that's helpful for the field. But my point is here is that we still are learning a lot about the Alliance in youth psychotherapy. All right, are you ready? I have another question for you. So if you please turn to each other, how do you define the Alliance? What does the Alliance mean to you? So the alliance between the client and the therapist. Why don't you talk a little bit? Thank you all for coming. Are you all looking forward to the party tomorrow? Will you all dance?
We'll see.
It was beautiful. It was sunny. We rode bikes. And, yeah, they were very. A happy birthday. It's very nice weather, so. Die Alliantie. I got that word. All right, how are you all defining the Alliance? What do you all, when you think of the Alliance, what are you thinking of? What does it mean to you all? What parts does it have, if any? Okay. Yes, yes.
Yeah, it's based on trust, and you feel the other sees you and understands you.
Good. So trust, sort of goal or going somewhere together, and hopefully you agree on where you're going, and kind of working together. Anything else comes to mind when people? That's a very good definition. Anything else comes to mind when? Empathy, okay.
And that it needs a lot of discussion or exchange about which images you have about goals or about what the problem is. That you really not, you often think, oh, we think the same, but it's totally different. Everybody constructs his or her world from his eye, but then you have to really to look for what do we mean and how do we go on. So a lot of talking and listening most of it, I think.
Very good. I think I think that's something that's many times overlooked. Is that does the Alliance just happen, or what can someone do to help strengthen and develop? And I think conversation, talking. It's almost in psychotherapy, you are developing a shared language with the client, and you may come in speaking slightly different ways, and you have to kind of make sure that you all are, what you say is understood equally across both folks, and you understand where you're going. So very good. There is, oh, yeah, sorry.
Yes, we were also thinking a bit, and I wonder what you think about that, how the concept is related to a more general thing in human relations, how you feel connected with other persons in sharing things.
So I'll have to say that there are in the field, there are a number of different definitions that are used. And on one side, people see the Alliance as just strictly what the relationship is between the therapist and client in that time. And other views very much say it's shaped by who the people are and what experiences they've had, maybe like their attachments, their relationships histories, and that history is in part seen in how the Alliance develops, evolves, or changes over time, and ultimately helps determine how the client does at the end. And so I think it's important to know, and it's a nice kind of segue into this, is that one of the challenges for the Alliance, and if you all are interested in studying it, is that there are a lot of definitions out there. And that's a challenge for the field, because that means that we've developed different instruments based on different definitions, and it means communicating across studies and so forth can be challenging. And so I found early on that it was important to provide a definition that I use and to help communicate that as clearly as possible, and realize that when people say the Alliance, they're not always meaning the same thing, both in research and practice. And so sometimes one of the first things, whether it's clinical work or research, one of the first things that's important to do is, what do you mean when you talk about the Alliance? What does it mean to you? What does it mean to when you're working with clients and so forth? These aren't the only definitions, but these are the main definitions that are used in the youth field. Back in 1979, Borden published a very important, influential paper. The Alliance has been around for over 100 years, the idea of it. Freud talked about it and so forth, and Anna Freud and so forth, and so it's been around for a long time. But up to 1979, the definitions were tied to theoretical orientations like psychoanalysis or psychodynamic and so forth. Borden, for the first time, said, I want to come up with a definition that can apply across no matter what the therapist is trying to do with the client. And he defined it as the goal or what they're trying to do together, how well the therapist and client agree about that, the task or the activities that they're trying to do in order to achieve that goal, and the bond, how much they like each other. So I think about it, if you're going on a trip together, say you're riding bikes somewhere, do you agree at the end destination? Do you agree where you're trying to go? The task is, do you agree on how you're going to get there? Are you going to go this way? Are you going to go that way? Do you agree on how you're going to kind of get to that place? And the bond is, do you talk while you're going there? Do you like each other? Do you enjoy each other's company and so forth? So this definition is one of the main ones used in adult psychotherapy. It's used with some adolescent research and many times when assessing parent-therapist alliance. Stephen Shirk, and if you haven't read his work, he was a great mentor and friend to me. He's now retired, sitting on a beach in North Carolina. In 1992, he was one of the pioneers of the Alliance in Youth Psychotherapy. He wrote a paper in 1992 for the first time saying, we need to study this in youth psychotherapy. And he argued for something called the collaborative bond. He said that young children are cognitively too young to understand long-term goals. And so he defined the alliance in terms of how well the child liked the therapist and agreed with what they were doing in each session. And so he developed an instrument, a self-report one that has been used widely across the world. And so you have one definition that's used quite a bit in the youth psychotherapy field, and the one that I largely adopted in my own work, and this one. And so, again, it's kind of going back, it's important to define and kind of what do we mean when we talk about the alliance. All right, let's talk a little bit about the evidence. Up to this point, there have been 3 meta-analyses published in the youth psychotherapy field looking at the relation between alliance and outcome. Stephen and I actually published one in the same year, back in 2011. Mark Carver published one just last year. Something that's a little bit frustrating about all of them, all of them end up with different numbers of studies, so it's a bit of a frustration. For some reason, my study has the most, even though it was published 7 years ago, and so people are still kind of struggling to define what to include when they're doing research reviews and what not, and so it still represents kind of some of the struggles we have in the field about what relationships are important in the alliance and so forth. So effect sizes. This is some way we judge the strength of the relation between the alliance and outcome. And in these 3 meta-analyses, this range from 0.14, which was my study, up until 0.22, which is the most recent one. So these are modest effects. This means that the stronger the alliance, the better the outcomes at the end of treatment. Now,
You also know the meta-analysis from Marianne Welmers? Huh?
It's not on psychotherapy. I think he's made analysis around psychotherapy.
I may have missed one.
It's on family treatment.
Okay, yeah, and so that's part of the struggle is, do we include couple and family and, yeah,
This is only
on child and therapist and parent and therapist, and so not family. And that's, so that is very important work that it looks at kind of almost family level. Another definition of the alliance. So I think it's important, do you think that the relation between alliance and outcome is higher, equal to, or lower than that between treatments and outcome? Do you have a guess? Higher? Okay, so we have higher. Got any equal or lower?
Only for the equal.
Okay.
me too.
So I think it's a very interesting question. Depending on the group that I'm talking with and interacting with, you get very different estimates. If you have a bunch of treatment researchers in the room, you get a very different response to John Weiss, who's known for doing a lot of meta-analyses. So John Weiss has done several large meta-analyses in the last 5 or 6 years looking at treatments in the youth field. And so the first one here I think is very important. He collected studies of evidence-based treatments conducted in community settings compared to usual clinical care. And what I mean by that, it's you have an evidence-based treatment and you're comparing it to what the child would normally receive should he or she seek treatment in that community clinic. And the effect size there is 0.14, which is on the lower estimate for Alliance outcome. Just last year, John and his colleagues, I'm thinking this is hundreds of studies across multiple settings, looked at the effect size for general youth treatment and found it was 0.22. The same range is for the Alliance outcome. This group published one on adult psychotherapy just last year and found a relation or effect size of 0.28, slightly higher in adult psychotherapy. And this was based on over 300 studies. So in the adult psychotherapy, there are many, many more studies on Alliance outcome. This may be a message that some folks don't like to hear, but the effect sizes are basically approximately equal. It has led to an increasing push to label the therapeutic relationship as an evidence-based principle. John Norcross in the adult psychotherapy field and Mark Carver in the youth psychotherapy field have made a good push, and if you haven't read their research, and there's some books associated with this, they publish books and articles supporting this idea that there's evidence-based treatments, but there's also evidence-based relationship principles, and one of them is the Alliance, and the ability to kind of assess for patient preferences and so forth. And so now, both the evidence-based relationship movement only started about 10 to 15 years ago, and it's gaining more kind of momentum, and I look forward to kind of where they go with it, because they wanted to make sure that they got relationship principles labeled as evidence-based as treatments had, and I think the evidence supports that. Yes? Oh, I wish we had more of that. Unfortunately, I think we sometimes research things we like or that we're invested in. It's not very scientific of us, but that does happen. And so oftentimes, people are studying one or the other and not putting both together. A doctoral student that is working with me right now, his name is Ruben Martinez, and he's doing a meta-analysis looking at the relationship between treatment integrity, adherence and competence, and outcome. And as part of that, he is hoping to highlight studies that include the Alliance in that. So far, he's only found one. He's not done with his literature search, but it doesn't happen. And so we need studies like that. How much variance in outcomes do each account for? So, but it's one of those gaps in the field, unfortunately. All right. Okay, taking a step back and looking across these three meta-analyses, something that has been a very consistent finding in adult psychotherapy is that the strength of the Alliance Outcome Association is consistent, no matter what treatment is being delivered, no matter what diagnosis the client has, anything. This relationship is consistent, but it's not in the youth psychotherapy field. Now, one reason this could be is that we simply have not accumulated enough knowledge Once you get over 300 or 350 studies, these estimates tend to stabilize a little bit more, and that may be the case in youth psychotherapy. But there also may be reasons that it does vary. Now, unfortunately, if you look across the 3 meta-analyses, what we call moderators, or things that influence the strength of the relationship between alliance and outcome, change from meta-analyses to meta-analyses, which is a little confusing, I will admit. But it looks like clients who are seeking treatment, the relation may be stronger for them. For the parent-therapist alliance, and it may vary according to the type of problem that is bringing the kid in for treatment. And we also have realized that we have a bit of a measurement challenge. There's over 15 child alliance instruments that have been used, and many of them are used once and then not used again. And this is a real problem. The multiple definitions and the multiple measures, it raises concerns. Are we measuring the same thing? There's more than 10 that have been used to assess the parent alliance, all with different definitions. And so I'm a little bit strange. I like assessment. I like measurement. Not everyone does, and I realize that. So this is kind of my own, we call it kind of my own pedestal or something, or my own message. But I think this is a real big problem. Science is about communication and creating ways of teaching what we learn, and if we're using too many measures, it raises concerns for me at least that we may not, all the accumulated knowledge isn't talking about the same thing. So conclusions from the meta-analyses, the alliance matters. Unfortunately, there's a group, if you look at the field, the alliance isn't always fully valued in the youth psychotherapy field. And due to policy and lobbying and political things, the people who develop treatments have done a very good job over the years in the United States, kind of arguing strongly that we need more and more and more evidence-based treatments. And the voices and the support for the alliance haven't been as strong in the United States. And so when there's these efforts to bring evidence-based practice into different settings in the United States, this is typically narrowly defined as treatments without the equal attention to what can we do to strengthen the alliance and the relationship between the client and therapist. But we have this challenge in the youth too. The Alliance Outcome Association may not be consistent. And if so, what are the implications for practice? And how can we address some of that through research? Interestingly, the Alliance may play a bigger role in community settings. And so following my own meta-analysis, I started engaging in some research to try to address some of these issues in the field. And I'm happy to send the articles here. I'm not going to go too in detail about some of the methods here, but I wanted to kind of share just a few findings that we've done to give you an idea of how we've tried to build off of these findings. A couple years ago, we had a unique opportunity where we had a treatment trial that we had youth diagnosed with anxiety disorder, and they're being treated with cognitive behavioral therapy. And we somehow convinced a group of graduate students to code 100 of these sessions with 2 different observer-rated alliance instruments. And we also had the fortune, so we had one in the first half of treatment and one in the second half. And then we also had the therapist reporting on the alliance and the child reporting on the alliance. And so we had this unique opportunity to compare, do these perspectives overlap? So here are the kids, about 51 kids, age 10, primarily Caucasian or white, pretty high income, and on average they had about 2.5 anxiety diagnoses. This is a pretty highly trained group of therapists. This was actually, anyone heard of Philip Kendall? the developer of Coping Cat. This was actually at Temple in his laboratory and it was part of a clinical trial. So these were graduate students, very highly trained therapists. We used the therapy process observational coding system, the Vanderbilt Therapeutic Alliance Scale, which were the two observer rated, and then Stephen Shirk's Therapeutic Alliance Scale for children, both for the child and therapist report. Interestingly, so I don't like always to throw too many numbers up, but the upper quadrant here are kids. The lower quadrant here is adolescents, and it was about 20-30 split, 20 adolescents, 30 kids. What's interesting here is that the child's perspective did not overlap with the therapist or the observers, and really not at all. Higher with the therapist, but really there was no relationship with what the observers were seeing. Whereas with the adolescents, pretty good overlap actually. They didn't agree nearly as much as the observers, and well, actually they did. The therapists, there was pretty darn good agreement across the four perspectives down here, which were for the adolescents. And what's interesting, and to remember, Stephen Shirk purposely argued that these two dimensions would be relevant for kids and adolescents. But the kids, the problem with this is that this shows that kids' perspective doesn't overlap with the other three. And we don't know if that is because we haven't designed an instrument that is usable by kids who are 8, 9, 10, and 11, or that in this case, maybe these therapists and so forth, or what we were observing wasn't as meaningful. So outside looking in, we weren't getting a good sense of what that child's experience was in therapy. But this does kind of raise some concerns that if asking the kid to report on the alliance, it raises concerns, are they reliable? Are they able to do that? With adolescents though, pretty good news. It overlaps. It's not perfect, but there is overlap. And so this is a pretty brief, pretty easy instrument to use, and I think can be incorporated fairly easily into clinical practice. And so there's good evidence there. So there's, depending on which version you use, there's anywhere from like a 7-item version up to 12. We were using the longer one, but they're both asking, I look forward to seeing my therapist. I like spending time with him or her. So there's a series of questions that focus on liking, trusting, bonding with the therapist, and then some about what he or she is asked to do in treatment. Like, you know, do you like what you're being asked to do? And so forth. And so it's tapping into the affective or the relationship dimension and the activity dimension, and asking the report.
From the adult version and the content.
So the therapist, you mean the therapist reporting? Interestingly, there's 2 versions. So if you ever use this instrument, be very careful, the Therapeutic Alliance Scale for Children. There's one therapist version that asks the therapist to say, what do you think the child thinks of your relationship? What do you think the child thinks? And one other that's worded, what do you think of your relationship? And so the confusing thing in the literature that uses this instrument is that you have to be very careful to know which version was used. We use the version where the therapist was asked to put themselves in the child's shoes. So and sometimes people use it without knowing, thinking that through or realizing, so, yeah.
I'm wondering, the Alliance outcome associations in child therapy, how do they relate to the different measures?
We didn't find any variability across that, but it also, we had found 15 different instruments, and there were only, I think, 44 studies in ours. So our ability to kind of group them down was difficult. When you look at the level of observer versus parent versus child, parents' report was one of the strongest. observer was one of the weakest.
And of the child?
It was between the two, if I'm remembering correctly. Don't quote me on that if you look at my article. But an issue with, and particularly for child therapy, and I used this argument for my dissertation when I developed our observational scale. My argument was we needed observer-rated measures because children may not be able to fully report. But the problem with the Alliance is that so much of it is what you agree on in therapy, that is the perspective of the individual involved. Observer likely misses some important information. So I'm kind of going more and more towards self-report probably being more valuable, and which I'll talk about at the end, but yes.
Yeah, maybe you mentioned it, but maybe I missed it. The Observer Alliance, was it videotaped and looked at afterwards?
Mm-hmm.
And also are the children, are they also looking at the tape, or did they fill in the question?
Okay, very good questions. I skipped over those details, by the way. In this clinical trial, all sessions were videotaped, or they tried to tape all videotapes. And in this clinical trial, at the end of the treatment, a research participant or assistant came in, the child filled out the Alliance, and they took it. They didn't give it to their therapist. We had research assistants watch these therapy sessions a number of years later, and at the end code the quality of the relationship between the therapist and the client. So,
Yeah, I was wondering, did they moderate also for the motivation of the child for therapy? Because I can also imagine that's the difference
Yeah.
between children and adolescents.
They collected some of those data, but it wasn't part of what we looked at here. But it's a very good question, because you wonder how their expectations and their motivation for treatment influences this, and it very likely does.
Yeah.
And so we took this, and again, one of my interests here is to try to address some gaps in the field. There's been this persistent issue in the field going back 20 years. So the evidence-based treatment movement started in the 1990s, and surveys during that time asking clinicians about using treatment manuals and treatment protocols with clients would consistently show that the clinicians were concerned that the use of treatment manuals would interfere with their ability to develop an alliance with their clients. And this happened over time and repeatedly across different samples when asking clinicians about using treatment manuals. We had an opportunity to, in a way, address this question a couple of years ago, and this paper was published a couple of years ago, but I wanted to bring it in here because I think it does address some potentially interesting questions. Is the alliance influenced by setting, or where treatment is delivered, or by the use of a manual-based treatment? We had the opportunity, Michael Southam-Grow and I got a grant a number of years ago where we had the opportunity to have videotaped therapy sessions from 3 different clinical trials, all for youth anxiety, for CBT for youth anxiety. One was conducted in a university setting where Phil Kindle had developed Coping Cat. And another was an effectiveness trial for CBT for youth anxiety that compared Coping Cat, the treatment that Phil Kindle had developed, to usual clinical care. So these were clinicians who were working in community outpatient clinics. Many of them had never delivered CBT, and they were doing it for the first time. And they were trained by us to deliver CBT, and then we can compare whether it worked, how well it worked compared to usual care. We, or the graduate students, coded all available sessions for all kids. For this sample, that means almost something like 850 sessions coded. Yes. If you ever want to learn about therapy, come to our lab. We've always got coding opportunities for people. Yeah.
Got 5 minutes till 1:30.
Oh, good. So I'm about halfway through my slides. Excellent. Yeah.
With the other slides,
Mm-hmm.
thank you. Community settings.
Oh, what are they like? So for this sample, this was conducted in Los Angeles County. And so they are, well, in the United States, we call publicly funded clinics. And so if a child and family in the community want to seek outpatient community mental health care, this is where they would go in their local community. So typically what you see is low-income families who have limited options will often end up seeking services in these publicly funded clinics. And so this is where the majority of outpatient mental health care is provided in the United States. And this is the focus of a lot of the work that I do, that trying to kind of figure out how we can improve services in these settings. I've got 35 more minutes to get through all this?
I think so. We have time left till 12 o'clock.
Okay.
But I can imagine so if someone
But if you
has
need to
any,
go, please.
and if you're not, please feel free to stay.
So what you'll see here a little bit is that here are the 3 different samples. The kids are about the same age. What you see, though, is when you have the community samples compared to the university, this sample is much more diverse, much lower socioeconomic status, meaning the families on average make a lot less money. They have higher scores on externalizing, meaning they're coming in with more anxiety and externalizing. And so the samples are very different. These 2 groups are receiving the same treatment, Coping Cat, but these are highly trained graduate students, and these are masters. Many of them, I have a slide on this. Many of them are social workers or MA level psychologists, and with only a few trainee psychologists. So the sample is very different. And what did we find? Because we had coded all available sessions, we were able to look at the Alliance over the course of treatment. It was statistically significantly higher in the university clinic. And it was both higher at the beginning of treatment and at the end. But it was also higher in the manualized treatment at the beginning of treatment, and by the end of treatment, there was no difference between the manualized and the usual care. I don't have this up on the slide, but we also had self-report. Now, we only had self-report at the end for the child, and it actually replicated this. Kids in the university clinic reported having a higher alliance with their therapist than those in the community clinics in CBT and usual care. There's different ways of interpreting this. One way of looking at this is that the use of treatment manuals may not interfere with the development of the alliance in community treatment. Another way of looking at this is motivation may matter. Phil Kindle he's got 600 publications. He's developed the Coping Cat. He's a luminary in the field of CBT for youth anxiety. His clinic is known nationally, if not internationally. People seeking out that treatment or that clinic likely wanted CBT for their kids. And I would argue they may want that type of treatment over and above who's providing it. Think about the individuals seeking services in publicly funded clinics. If you've worked in those types of settings, some people have been in treatment before, some have not. They have different expectations about what's going to happen. Some come in thinking, yeah, it's kind of like a doctor's visit. It's going to be 1 or 2 visits and that's it. So different expectations, different kind of relationship. There may be more of a kind of importance put on who's providing the treatment in the community clinic and whether they hit it off than in the university clinic where the motivations and expectations of the clientele may be very different. I've worked in both specialty settings and community settings, and my clinical experience would suggest that the expectations and the motivations of the clientele in both are very different. And so this does suggest that treatment manuals may not interfere, but I also think the other thing too to remember is that motivation and expectations may matter, and we may need to help train individuals to kind of take that into consideration when developing an alliance. All right, I want to make sure I get through. Yeah, I'm good. So, alliance building. I know some folks do some training on this here, and this is an important topic. Going back to our model, and when I was preparing the slides for this talk, I was trying to kind of figure out, since we had written that chapter a couple years ago, what more research has been done in this area. And I'm sad to say there's not a lot of research that looks at the relation between what a therapist does, how competent he or she is, and the extent to which that predicts the alliance. I'll be a little provocative here. I know this isn't a view that's held by anyone, but in part, I view the alliance as an outcome. It's a product of something. And what is it a product of? What can a clinician or a therapist do to strengthen that, to develop it initially, but also maintain it over the course of the relationship with that client? I personally view this from my training experience as something that we need to start with when training clinicians, that this is foundational, that this is a core competency, that I think a clinician needs to show evidence of the ability to kind of form an alliance and relationship with the client before you start building on the techniques to change or help promote change in that client. And that's my value, that's my kind of belief and so forth, but we unfortunately don't have a lot of research to rely on. Kind of a broad summary for youth is, don't be overly formal, be very genuine. Kids, and especially adolescents, have kind of radar for times when people are not being genuine or truthful or straight with them. Be consistent and transparent, especially for young children who are forming a relationship. You need to, provide a structure for them, and consistency and predictability and so forth, and be on their level, and kind of don't go too fast. For someone who enjoys music, I always think of it as, you have a metronome or something that keeps the beat, and you have to kind of figure out how quickly or slowly that you can move with a client and keep them engaged. And the younger the child, the less content you're going to be able to get across to them over the course of a session. But coming back to this, make adjustments based on youth characteristics. To me, competence for a therapist is knowing what he or she wants to do, but being able to adjust what they do. Am I going to play with them? Am I going to do puppets? Am I going to do art? Am I going to talk with them? Adjusting how you deliver it in order to achieve your goal and deliver that content within a strong therapeutic relationship. But of course, with a youth, you have caregivers. And you have to develop a strong relationship with parents and caregivers. In the United States, because of many of our laws, in most states in the United States, you need parental consent up through 18 in order to provide psychotherapy to the child. So if you don't engage the caregiver, they're not going to pay, and they're not going to bring that child to treatment. Negotiating an alliance with the caregiver and the adolescent can be tricky. They don't always, and actually most often, do not agree on the need or the focus of treatment, and that's just the plain reality of it. But you have to kind of negotiate with them and find a shared focus, or they may not come back. So you have to find common ground with them, and again, kind of make adjustments based on their characteristics and so forth. Now, the further I get, and this is a kind of an area of research that I'm pursuing these days, is measurement-based care a term that folks know of or are aware of, or kind of some? We have some pretty good research now emerging that if you collect each session, outcomes, and the alliance, and you just give that information to the therapist or the clinician, you don't tell them to do anything differently. You just give that information to them. Clients stay in treatment longer, and they get better outcomes. It's like an early warning center system. So a red light that goes off. If the alliance starts to deteriorate, the clinician knows. If the outcomes start to go down, they can have a conversation. In the United States, there's more and more of a push to make what we call measurement-based care a routine part of clinical practice. And I would argue that I think this is a very kind of important potential tool that we have, especially as electronics make this easier to do, to help strengthen and maintain the alliance over time. Because most measurement-based care systems these days include alliance instruments. And they do, and the evidence suggests that they do help. Okay, some future directions, and then we will open it up for some questions and so forth. I'm increasingly kind of, so just like we haven't looked at techniques in the alliance together, there's very, very few studies that have looked at multiple perspectives. The few studies that have suggest that when there's imbalances between the parent alliance and the child alliance, the clients don't stay in treatment as long. So this idea of discrepancies between the different alliances that form may really matter. And so I think as we go forward, when we study the alliance, it would be very useful to have multiple perspectives, because combining them may be more important than looking at them individually. Measuring the alliance across treatment, as I mentioned, we have now coded almost, I didn't do a lot of the coding, but 1,600 sessions. And across the different trials, usual care and CBT, alliance actually seems to decrease over the course of care. Why? What should the alliance look like? Should it go down and go up? Should it get more? Should it go down? We don't know. And it would be useful in terms of measurement-based care, if people are supposed to stay straight, but they start going down, that would be useful to know. It would be useful as a feedback system. And this, critically, what therapist behaviors are linked with the alliance? I would like to know that because I train folks. Anybody here of shared decision-making? Yes, okay. This is an article that came out by two good friends of mine and old lab mates. This is a process that is used in the medical field, and this is very much based on information in the medical field that says a well-informed patient that knows about his or her condition and the treatment options, and a provider who is also well-informed, are better at collaborating and talking and generating effective care. So the more you can educate and get a client knowledgeable about his or her, what's going on for them and the treatment options, the better you can have productive conversations. And so David actually has a grant right now trying to translate this method into use for youth mental health care. And so it is one of the few structured processes I've seen that you can teach clinicians to engage in a structured conversation with an individual or family to get out treatment goals, to talk about treatment options for those goals, and to help them basically engage in a conversation that will touch on the elements of the alliance, and then to revisit it as needed as treatment progresses. It's shown very good effects in the medical field to help ensure that patients have a voice in their care and are knowledgeable about what their treatment options are, so that care isn't just coming from the doctor to the patient, but it's collaborative. And so this, I think, I actually plan to incorporate this into the graduate course that I teach as a way of engaging with clients in a structured way to help touch upon and build the alliance. I also think that some tools out there, has anyone heard about the cultural formulation interview? Good. There's American Psychiatric Association as part of the DSM, which I don't particularly like the DSM, but this is actually a good tool that came out of it. It's something that you can download for free off the internet, and it's a wonderful resource because it has questions that you can ask clients about religion, about culture, help seeking, their beliefs about what they're suffering from. And so oftentimes when I'm training folks for the first time and trying to help them understand how does culture and religion impact how you go forward in treatment, people struggle with how to form those questions. What do I say? How do I start the conversation? So this is, it's a, I think, 8 to 10 page guideline that just offers people ways of starting the conversation and ways to follow up. And you can take that information and use it to gather information in this way. So I think shared decision-making may be an important way of engaging in evidence-based practice, because even if we know the research evidence, to me that's not usable unless you can use and develop expertise that will allow you to understand about patient characteristics and so forth. So we have about 15 minutes for questions. I know I wanted to get through the end, so I wasn't as open to some questions at the end. So what do folks, do you agree with this? Do you disagree? Do you?
I watched it. It's a lovely presentation.
Thank you.
I was wondering what we are sometimes looking at when we're working in the field. Then how do we get this knowledge into the backpack of the therapist and the scholars who are training to get into the field? And what's your experience with that?
It's challenging. So some of the work that I'm interested in is of helping to kind of understand what can we do within curriculums. So when we're training at the master's level, because at least in the United States, if you look at who's providing treatment, it's primarily master's level, social work, psychology, and so forth. So you have 2 years. What tools are you going to put in their toolbox? I think there's a lot of emphasis on treatment strategies, but I think shared decision making, or something that's fairly short, fairly easy to learn and structured, like that, I think is a very important tool. One of the primary reasons I like it is that it's not that complex. I think it can be done with some practice, and that it may help, especially if combined with something like the cultural formulation interview or something like that, can help clinicians start the conversation and get to, why are you here? How can I help you? And so I think embedding that in the curriculum might help, but working with people who are already having been practiced, I actually think in some ways, in many instances, this, like the shared decision making might be an easier sell if you can kind of say, this might help you engage or connect more with your clients, which is sometimes, in my experience, easier than saying, hey, there's an evidence-based treatment I have for you. And some people are very welcoming to that and some people are not. But I find that kind of talking about alliance and engagement, many people, and myself included as a clinician, I struggled with that. You know, that's something that we oftentimes see a lot of people struggling with. So I think sometimes it's something with shared decision-making that's not a big ask, that it's sometimes a tool that can be offered and people maybe positively respond to it. So it's challenging though, because you have people who are in the workforce and working, and then we have the people who are coming through the training, and we can't, the same strategy won't necessarily work for both. Yep.
I was thinking about some things, and I don't know, I was struggling with language, Dutch and English. But I was curious about your opinion about it, because you have in the United States, you have the Deze and around solution-focused approach.
Mm-hmm.
And when I was thinking about this, what you said now about shared decision-making, and there are a lot of, from my point of view, a lot of similarities in the approach of the Deze and Kinder.
Solution focus, yeah.
But what do you think about that? Because it's totally not, do you have an idea how you would use it for research, for example? The questions in it are very much focused on to get to know the patient, to get a good relationship, not focusing on problems or on diagnosis, but on the problem what the client sees. So what do you think about that?
Yeah, I'll admit I'm not an expert in solution-focused. I know that it is used in the United States some. My impression is that it's longer than the shared decision-making. That shared decision-making is kind of something that you usually do at the beginning or close to the beginning. That's a session that hopefully that you use to kind of a formal process, used to engage in a conversation that, and it's presented as this is an ongoing thing. We need to revisit this as we go, and you know, if we're talking about something and we agree today, but in a month we don't agree, we come back and we use this form, you know, this framework again to kind of revisit. Whereas solution-focused therapy is more kind of almost like a program of therapy itself that's very client-oriented and solution-focused and pragmatic, but similar goals, but not quite the similar format and so forth. And what we were talking about earlier, one of the reasons why I kind of like this and the way that David is going about studying this is trying to see, does it have short-term impact on alliance and engagement and attendance? Because if you look at many of our statistics in the United States, we have a huge drop-off after the third session. You know, only about 2/3 of the clients get there. And then we see another drop-off around 10 or 12. And so there's these kind of key points where we can do a better job of keeping people in treatment, hopefully. Now, it's not always dropping out because they disagree with the therapist or what they're doing. There's many barriers that they experience to getting to treatment and so forth. But if we can introduce something that might help get people on and keep a higher percentage in, but also then engage in bringing in the treatments and evidence and what we know works, I think that combination, and that goes back to my bias, which is we need more evidence-based strategies for developing the alliance, which this may help, and then a way of then trying to figure out of the evidence-based treatment options that are available, which would be the best fit for this patient's preferences and desires. Does that make sense? So this, I think, is a kind of almost opens the door for evidence-based treatment options, but a way of engaging with them about because if you have a family with a particular cultural or religious belief, some parenting programs may actually go against or work against the parenting beliefs that they have. And if you don't talk about that up front, then that's not a good evidence-based treatment approach for them. If you're actually kind of undermining the parenting values that they have, you're not going to. So I see it as kind of a combination of the two, if that does that make sense? Or, okay. Yes?
You compared 3 different therapist groups, Alliance,
Mm-hmm.
3 different groups, and I was wondering if you talked about those results with those groups of therapists, and then especially with the ones from the community centers. What do they recognize it? What is their explanation for the difference?
I wish we had been able to. We were actually coding these sessions anywhere from 5 to 8 years after. These kids are adults now. But there is some research that's done on how therapy works that actually involves watching videotapes with therapists or clients, asking them what their experience was. And I would be very interested to kind of, what level of insight do therapists have when a client is rating them as low on Alliance or high or so forth? Can we train therapists to be more attuned to the signs that a client is not engaged or not fully kind of bonding with them? Because that's something that, again, a core competency that can a therapist track and realize and identify emotion? But we didn't have that opportunity for this particular study. Those kids, they're not kids anymore.
And did you also account for work conditions from people from the different groups? Because I think that in community centers the workload is much higher.
Yeah.
So maybe they have less time to really
Oh yeah, they certainly, yeah.
develop a bond with their patient.
Yeah, no, and that's one of the ways that we were considering it. I think in this talk I focused on potential differences in the kind of expectations and motivations of the client. On the other hand, you can't overlook the differences in a graduate student who has 3 or 4 clients that they can spend an hour or 2 preparing for the session. They don't have to fill out a lot of paperwork after the session. And a clinician who, this is one client of 6 or 7 during the day, very little time to prepare and so forth. We couldn't really control or account for those other than saying that the differences seen may be explained by that. It could be the clients, it could be the setting. There's differences, but we can't fully say why. So it's a kind of more descriptive than explanatory study. But you're right. The problem, if I'm to critique that study, the biggest issue with it is that it raises the issue of these differences, but we can't say definitively why. Hopefully somebody will pick that up and run with it.
What did the practices themselves, what did they think of it? Have you talked with them about these results?
No, we were very interesting. Well, and so the clinicians that we do work with are very invested in the Alliance and so forth, and they often have questions about what their clients think, and if they don't have some sort of system in their work, to kind of assess for that. And oftentimes too, they struggle with knowing how to start conversations about that. And they might think that some things is not going as well, but then the question is, well, how do I bring that up? How do I bring it up with a child? How do I bring it up with an adolescent? How do I bring it up with a parent? So they might notice it, but then they struggle with, okay, what next? Yes?
What do you think about feedback-informed treatment or using the outcome decision-making skills as an alliance building technique?
Yeah, I think it's, I increasingly kind of, and this links up with shared decision-making, because I think that it's the principle that a number of feedback systems actually take the information and are designed to both give it to the client and the therapist. And so I think the more informed clients and therapists are about how each is perceiving treatment, I think overall the evidence suggests that that is going to lead to a better alliance, better attendance, engagement, and outcomes. And so I actually, in our training program, we strongly emphasize the importance of regular outcome and alliance monitoring and using that to guide case conceptualization and so forth. And that's not something that we're talking about today, but I think like case conceptualization and having an idea of what you're trying to do and so forth, feedback's very important because we all make judgments, clinical judgments, errors in clinical judgment. We think it's one thing, but it's something else. And I think data helps correct us if we think we're going one way, but we're not. Oh, I have a great alliance, but then the data suggests not. But if I don't have any data coming in, then I may keep going thinking it's a great alliance, and then they don't show up. Not good. So. Well, thank you all. Yeah.
May I close by asking you, is that the kind of question?
Of course.
Can you imagine forms of psychopathology or client issues and or types of interventions where alliance might be a hindrance rather than a core element?
Well, and that is kind of an ongoing debate about whether the alliance is therapeutic or not, or it's something that is facilitative. It kind of makes things easier but isn't necessary for change. I would say, it's a good question. I actually haven't thought about it before. But my experience across different settings, if I'm working in an inpatient setting, I've got 5 days. Sometimes my job is to deliver a very heavy-handed message. This change needs to occur, and that in order to, if I have another team member who has a long-term relationship with this person, I may sacrifice some of my own relationship with them to deliver a stronger message or be more heavy-handed or so forth. So I think the alliance is something, and how it manifests itself varies across the setting and the length of the relationship you may have, and that I think to some degree, liking is important. They're not gonna, if you're too heavy-handed and they don't like you, they're not gonna, I don't know how many people play poker, but if you think about poker, if you're working with a client and you don't have any chips to spend, well, they may not listen to you. I mean, you need to accumulate some chips with a client before you can spend and ask something of them. And so, to me, there's not too many instances with that, but I would say maybe some in crisis care or something where you have a more short-term relationship and you really need to kind of jolt them into action. This will not, if you continue doing this, this is going to lead you to, bad, suicidality or something like that, so. Yeah. Mm-hmm. Yeah.
Please do. That leads me to something what I was thinking about. That if you work in a psychiatric hospital, then you have a lot of with children. Then you have a lot of systems with a lot of pressure,
Mm-hmm.
and also parents with complex trauma, but also the children.
Yes, yes.
So are there studies with those, or is there evidence found how the alliance works in that context? How is that?
There is some work from the United Kingdom, and we were actually talking about this a little bit this morning, is that, so it goes back to that idea of the definition of the alliance. With who is the alliance important in a setting? In that instance, if I'm working in an inpatient setting and I can come in as a heavy hitter, their relationship with me may actually not be as important with the nurse practitioner or the nurse or the daily staff that's working with them day to day. Their actual bond and relationship with them may in some ways be more important. And so what they've done on inpatient wards in the United Kingdom is they've done the alliance between the client and nurses or the staff that they're interacting most with, and who are often the ones trying to get them to do the day-to-day things and help them along and meet their goals and so forth. So in those settings, when you have a team of people caring for an individual, that's where I think you can start, and that was partly my response there, is that if you work well together as a team, you can decide what your roles are and what needs to happen and how to kind of coordinate together in order to kind of achieve that goal. And that might mean someone kind of comes in a little bit heavy-handed, but that's delivering a message, somebody has gravitas and kind of somebody will listen to. But since they're only seeing them maybe once a day, the bond is not quite as important with them. because they're going to be with the other people all the time, and they're going to be helping them carry out. So,
Depends how you use the people
yeah,
to help and
yeah. I think the strongest units and teams are the ones who are able to talk about those things and strategize and work and kind of figure out who's going to be able to develop the strongest relationship, and how can we help use that to help the individual, and what other roles can people play to kind of, you know, promote change in the family system and so forth. So.
Okay.
Thank you all.
We're done. Thank you, Bryce.